So, good morning, good evening, and good night to everyone from across the globe that's joining us for this edition of the EIOC Journal Club. Today, we're going to be talking about updates on first line HER2 positive metastatic breast cancer. As you know, there's been an explosion of data looking how you integrate antibody drug conjugates both in the metastatic as well as early stage setting in patients with HER2 positive breast cancer. But today we'll focus on that first line MBC setting. My name is Shahina Dawood, and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates. And today I'm joined by some spectacular faculty, both regionally as well as internationally. So we'll start off with the very well-known Paolo Tarantino. Please give us your introduction.
Hi, everyone. I'm Paolo Tarantino from Dana-Farber in Boston. Such a pleasure to join this program. I'm sure we're going to have great discussions.
Absolutely. Basil.
Good evening, and I'm Bassel Jalad, also all the way from the neighborhood city of Shahina's, Abu Dhabi. I work at Cleveland Clinic, Abu Dhabi. I'm happy to be with the team here and with my best brother, Paolo Tarantino.
Imad.
Hi everyone, I'm Imad Dawood, the medical oncology consultant from Town Hospital, UAE.
Fathi. Fathi is actually my partner in crime and knows never to disagree with me. Fathi.
Yeah, Fathi is really medical oncologist, American Hospital, Dubai.
Hussam Marashi, who likes to always disagree with me, but I always win the argument. Hussam.
As you know, I always enjoy this discussion, Shahina. I'm Hussam Arashi. I'm a consultant medical oncologist based in Al east of the United Arab Emirates.
And my best bud, Sonia. Sonia, you come all the way from Abu Dhabi as well. Please introduce yourself. You're muted, Sonia.
Hi, good evening, everyone. It's Dr. Sonia Otsmani from Bardil Medical City. Thank you for inviting us.
Thank you. So without further ado, like I said, we're going to be focusing on first-line HER2 positive metastatic breast cancer. And then we're going to have a panel discussion where I'm hoping to ask those really tough questions. But first off, I'll hand it over to Paolo, who will just be taking us through the latest data. Paolo, take it away.
Wonderful. Thank you for this introduction. I'm assuming all of you are seeing this. We're going to have a wonderful discussion of all of these new options that we're having for treating patients with metastatic HER2 positive breast cancer. And these are my disclosures. And so why are we talking about this? Because still HER2 positive breast cancer, we're getting better at curing it, but it still exists and it still unfortunately develops metastasis. And that's the bad news. The good news is that we are having more and more drugs to treat it and to make it kind of a chronic disease more than other subtypes. HER2 positive breast cancer accounts for about 15% of all breast cancers. And usually it's HER2 enriched in terms of biology, but we know that some tumors, especially those that are also estrogen receptor positive, can be also luminal in terms of biology, which is very relevant for the treatment. One other relevant thing to remember for treating patients with HER2 positive metastatic breast cancer is that not all patients reach the second line of treatment or the third line of treatment. Now, there is some discrepancy among the studies that look at this question, how many patients do not get to the second line or third line, but we're sure that there's a percentage of somewhere around 10 to 30% of patients that may not receive second or third line therapy because of worsening general conditions, because of progression of disease in the brain, in areas of the body where it can be particularly symptomatic, which is a reason to try to utilize our best regimens as early as possible for this metastatic disease. And in the first line setting, for about a decade, we've been utilizing the Cleopatra regimen, which basically was developed. We will see some data about it, but as you all know, it consists on a taxane, first docetaxel, combined with dual HER2 blockade with trastuzumab pertuzumab, and then in time, this regimen was refined because the Peruse trial showed that you can use other taxanes. The results are basically consistent, paclitaxel or nab-paclitaxel. So we usually utilize paclitaxel with the Cleopatra regimen. Then Emerald, the Japanese trial, showing that eribulin also is the same efficacy when utilizing first line. Pertain showed that also endocrine therapy, when combined with dual blockade, is highly effective. And then we will see some additional studies. But there are still major unmet needs in this setting. First of all, as I mentioned, for a decade, we've been using the Cleopatra regimen. And so while there was plenty of new regimens for pretreated HER2-positive breast cancer, there's been some lag in first-line treatment advancements until 2025, basically, where everything changed. Then patients with recurrent disease. So as I mentioned, we're curing better and better early-stage HER2-positive breast cancer, but those tumors that end up recurring tend to be more and more aggressive because they are highly pretreated with trastuzumab, pertuzumab, T-DM1, and so we do need to better treat these tumors. Visceral and especially brain metastases are a huge unmet need. We are developing better treatments for this. HER2 Climb was one of the first trials. ADCs are coming, but definitely they remain a poor prognostic factor. PIK3CA, I think we can discuss this afterwards in the discussion because it's emerging as a very relevant prognostic factor. We have always known it, that in Cleopatra, patients with PIK3CA mutations did worse, but we never really looked at it. And I think right now it's worth discussing, is it worth to look at this mutation in this setting? And we can discuss. Finally, hormone receptor status. For a while, we've been treating patients with hormone receptor positive and negative HER2 positive disease kind of in a similar way, but their treatment is kind of evolving in different pathways over the past few years. So let's review one key advancement that we've seen basically over the last year for untreated, for metastatic HER2 positive breast cancer. And this basically is leveraging all the knowledge we developed over the past 5 years with T-DXd, trastuzumab deruxtecan, an anti-HER2 antibody drug conjugate which delivers DXd, a topoisomerase 1 inhibitor, into HER2 positive tumor cells. And there is some preclinical data suggesting that the addition of pertuzumab to T-DXd can further enhance internalization in the tumor cell and delivery of the chemotherapy. And this has prompted the design of Destiny Breast 09, trying basically to take a drug, a highly efficacious drug, T-DXd, which has been proven to be so effective in highly pretreated patients in Destiny Breast 02, in moderately pretreated patients, Destiny Breast 03. Now we're taking this drug. It was taken to the first-line setting with or without pertuzumab. And Destiny Breast 09 was a phase 3 trial for patients with HER2-positive metastatic breast cancer, which could or could not have brain metastases that are asymptomatic or inactive. Patients that had a disease-free interval of at least 6 months could be enrolled. Endocrine therapy was allowed, permitted, but no prior chemotherapies or other systemic therapies. Patients randomized to T-DXd placebo, T-DXd pertuzumab, or standard Cleopatra regimen, with the catch that the T-DXd arms involved giving T-DXd indefinitely, whereas for the taxane, there is this induction phase, as basically we've been used to do for many years, followed by basically maintenance antibodies. The primary endpoint of the trial was PFS, key secondary endpoint overall survival. And so for the moment, we only have data with T-DXd pertuzumab versus THP, and the population that was included in this study basically was composed by half of Asian patients, the other half Western Europe, North America, rest of the world, most patients with good performance status, HER2 3+ disease, almost evenly split between hormone receptor positive and hormone receptor negative, most patients with visceral metastasis, and about 5 to 6% with brain metastasis, 30% at PIK3CA mutations. So when you look at prior treatments, of course, they did not have treatments in the metastatic setting apart from endocrine therapy for very few patients, only 5 patients in each arm. But in terms of prior therapy for early breast cancer, about 40% of patients received chemotherapy, 30% trastuzumab and other regimens. So when you look at the primary endpoint, there was a striking improvement in progression-free survival. So PFS in the control arm, in Cleopatra, it had been 18 months. Here, the control arm performed a little better, probably because of the implementation of endocrine therapy, which was not allowed in Cleopatra. So with the control arm, THP, 26.9 months. With T-DXd pertuzumab, 40.7 months, as a ratio 0.56, which was statistically significant. You can see that the curves diverge approximately at 3 to 4 months, and they remain separated, which to me kind of means that when you start omitting, when you stop the chemotherapy in the THP arm, inevitably some tumors will start to progress. Whereas with the ADC, there are no cumulative toxicities like neuropathy. And so there is this possibility to keep those aggressive tumors in check. So PFS improved. And when you look at subgroup analysis, the key subgroups of stratification all showed an improvement, de novo versus recurrent, HR positive and negative, PIK3CA mutated or not, and across all of the other subgroups, there was an improvement. All of the other ratios are less than 1, basically. And when you look deeper at the subgroups, you can see that both patients with de novo disease, which usually tend to do better, but also with recurrent disease that have worse prognosis, had an improvement in PFS with T-DXd pertuzumab, with an hazard ratio that was relatively similar, 0 to 5, 0.5, 0.6, and you can see there is a clear improvement in both populations. Hormone receptor positive and negative, also there was a very similar improvement, as a ratio 0.5 to 6 in terms of PFS improvement with T-DXd pertuzumab. Finally, in PIK3CA mutated disease, on the left, you can see that the Cleopatra arm did definitely much worse, 18 months, compared to the standard population, whereas with T-DXd pertuzumab, this was kind of rescued. There was double the PFS in this population, but also in not detected, there was an improvement. And the other ratio was not too different, once again, around the 0.5, 0.6 range. Finally, response rate was not too different among the two arms, 85% T-DXd pertuzumab, 78% with the Cleopatra arm, but the complete response rate was higher with T-DXd pertuzumab, 15% versus 8, basically doubled. And we know that in this population, complete responses are relevant because we do see some patients that never progress to first line, and usually these are the patients that experience complete response. So we are hoping, we need more follow-up, but we're hoping that these are prolonged responses. And also, usually after a while, the complete response rate tends to improve, because in Destiny Breast 3, that was second line, the complete response rate with T-DXd was 21%. And so I do think these numbers will increase in time. Side effect profile wise, they were quite different, because with T-DXd, as we know, we tend to see more nausea, diarrhea, and some fatigue. But overall, even with THP, there was a little less nausea, but still some diarrhea, neutropenia, and fatigue. Alopecia was seen in both arms. Much less neuropathy, of course, with T-DXd pertuzumab, as you would expect. So overall, different, but not too different. And I think it's important to remember that nausea can be very well prevented with T-DXd pertuzumab. These clinical trials, the Destiny trials, do not mandate maximal anti-emesis, but I do think it's worth to always consider 2 to 3 drugs, better 3 drugs, antiemetic prophylaxis upfront. In terms of ILD, no surprises. Across trials with T-DXd, there's about 12% rate of ILD, in this case 12.1%, 2 grade 5 events, 0.5%, and only 4 cases of grade 1 and 2 ILD with THP. Cardiotoxicity-wise, relatively similar, no grade 5, only 1 grade 4 with T-DXd pertuzumab. So in this trial, it's important to realize that with T-DXd pertuzumab, even if patients received it continuously, if they stopped tolerating it, they could discontinue and continue only with trastuzumab. So kind of as a continuous, let's say a prolonged induction followed by some maintenance. So this was possible in the trial. In terms of tolerability, you can see that there was no striking differences with T-DXd pertuzumab compared to THP across the 9th cycle. We don't have much data beyond, but if you look till the 9th cycle, the tolerability of the patients, they didn't seem to be bothered by treatment too much. And in terms of treatment-related symptoms, it does seem that in terms of fatigue also, there wasn't much difference across the 2 arms. And in terms of arm symptoms, there was some improvement actually with T-DXd pertuzumab. In terms of physical functioning, also the curves were quite similar overall. So the quality of life to this moment seems quite similar. I'm sorry for not including it here, but GI symptoms were a little worse with T-DXd, as you would expect, because of mostly nausea and diarrhea, which is seen more often. But overall, most of the domains in quality of life were actually maintained or improved, which in some cases is related to the improvement in symptoms from the metastatic breast cancer, which is also relevant. So some thoughts here. this trial definitely led to an approval and the utilization now of TDXD pertuzumab in the first line because it allows for a more prolonged control of disease. This is actually the longest PFS ever reported in the first line. And we're not talking maintenance trials. Was not a maintenance trial, it was an upfront trial. 40 months was quite remarkable. Rates of complete responses were relatively high, 15%. We hope these patients respond for a long time. Important to remember to use antiemetic prophylaxis with TDXD, as you all know, and also monitor the lungs, because across trials, we do see that TDXD can cause interstitial lung disease. Some trials report also fatal cases. In this trial, 2 cases. Important to remember this. Of course, important to realize that there's additional innovations that arrived over the past year. Patina and HER2 CLIMB-05 are the 2 main innovations. Patina was a trial that is a bit different because it was in the maintenance setting. After induction chemotherapy, trastuzumab with or without pertuzumab, the patients were randomized to receive either endocrine therapy, trastuzumab, pertuzumab, or endocrine therapy, trastuzumab, pertuzumab, plus palbociclib, which we know works in HER2 negative disease, a CDK4/6 inhibitor. And the question here, does it improve PFS also for HER2 positive disease, positive, HER2 positive in a maintenance phase? Important to realize the patients that had a rapid progression on induction chemo were excluded from this trial. This trial only allowed enrollment if the patient had controlled disease after induction. So there was some selection for a more benign, let's say, features of disease. And here there was a major improvement in PFS from 29 months with the standard endocrine therapy HP to 44 months with the addition of palbociclib, as a ratio 0.74, statistically significant. So definitely an improvement, although here we're talking of a different setting, the maintenance setting among patients that have positive disease, that usually have better prognosis, and that were beyond the induction therapy without progression. And finally, HER2 CLIMB-05, very similar design, although here patients with both estrogen receptor positive and negative HER2 positive disease could be enrolled. And after induction, THP without evidence of progression. So also here, there was some selection for more benign features. Patients randomized to either just maintenance HP with or without endocrine therapy. And about 40% of patients got endocrine therapy here, or with the addition of tucatinib, a drug that we use in the pretreated setting. Here it was tested in the maintenance setting. Primary endpoint, investigator-assessed PFS, which was improved in the overall population from 16 months in the control arm to 24.9 with tucatinib as a ratio 0.64, statistically significant. But most of the improvements was seen in patients with hormone receptor negative disease, where you see a doubling of PFS from 12 to 24 months. We don't see here the striking medians seen in Patina and DB09, and it's hard to understand why in truth. But overall, what's relevant is that the hazard ratio was favorable and there is a relevant improvement. So we expect that this may become available in the future in the clinic, although it's already available for pretreated patients. So here we don't know if using the drug earlier really makes a difference in the long run. For hormone receptor positive disease, not much difference actually. You can see that the curves are quite overlapping as a ratio 0.72 here. Side effect profile, tucatinib definitely added some diarrhea, nausea, and especially liver toxicity in this maintenance phase. So it's important to remember that tucatinib does come with side effects. Take-home messages for all of this is that after a decade of having one standard, now we have multiple standards. I do feel that only one trial really replaced the overall, induction phase. TDXD pertuzumab was tested from the upfront, from the moment the patient is diagnosed, and showed the longest PFS in that setting of 40 months. But now we also have these options of Patina and HER2 CLIMB-05 for the maintenance phase. And we have an amazing panel to discuss how to try to think and merge all of this emerging data. Things that are important to remember is that when you have multiple available regimens, you can tailor, you can understand what are the preferences of the patients, what are the different tolerabilities of the regimen, and this is going to be important in the future. And of course, trying to understand how to maintain the patients in the best possible way. And for those that have aggressive tumor features, probably the best possible way is to continue cytotoxic treatment for longer. And TDXD does allow for this. Thank you all.
Thank you, Paolo. Like I said, explosion of data, meaning multiple choices for our patients. Now, I do have so many questions, but I'm not going to show the slide of the questions. I'm actually going to show your own slide because I'd like to really look and tease out, if you don't mind, to actually look at the trial itself. So, Paolo, I think perhaps you're the only one who will be able to answer this. Why hasn't the TDXD alone arm actually read out? Why have they only read out TDXD plus pertuzumab? Is it that TDXD alone is just simply not enough?
Great question. And actually, I was surprised because I asked this question to my boss some time ago, who presented this trial, Sarah Toleni. And
Yeah.
basically, she came out with this detail that is buried in the protocol, which I was not aware at that point. I am aware now that the statistics for the two arms, the two TDXD arms, were different. The alpha allocated was different, and so the number of events required was different. And simply because of that, there may be a difference on when they report. So I think right now, with what we know, it's impossible to tell if TDXD alone is better or if it's worse. And of course, it's open for bets. And if I had to bet, I think the pertuzumab adds a little. Not that much, but I think it adds a little, especially in the maintenance phase, because many patients did discontinue TDXD in the trial. The median duration of TDXD was 20 months, but the median PFS was 40 months. And so when you drop the cytotoxic, I do think that pertuzumab helps. And I think we're going to figure out, hopefully soon.
So, I'd actually asked Sarah the same question and she gave me the same answer. And what I told her, I'm going to tell you, I said, I've done all this statistics, and I've studied statistics, and I can tell you, no matter what you tell me, the fact is, if TDXD on its own was really much, much better than THP, we would have seen some difference by now. Someone would have reported something by now, but I may be proven wrong in the future. My second question to you is that you mentioned that the protocol did allow for patients who'd gotten off TDXD for some reason or the other, that discontinued it, to go on to use trastuzumab. In that case, what were the percentage of patients that actually went on to use trastuzumab, and did they use it alone, trastuzumab, or trastuzumab plus pertuzumab?
So great question as well. And I think in truth that we need a sub-analysis for that because we don't have detailed data. What we know is that since the average duration of TDXD was 20 months and for the PFS was 40 months, I expect a relevant proportion of the patients. But for now, we don't have great details on this. So I do think we need to look in depth. And I believe it depended on the arm because TDXD alone, they could go on trastuzumab alone. TDXD pertuzumab, they could get HP, but it's just like, I think we're still kind of in the darkness in this setting, and we need better data. There is, of course, as you know, an ongoing trial of maintenance HP after induction TDXD, the Demeter trial, which will kind of help, although I'm still not convinced that 6 cycles are enough. I do think that the fact that you can give TDXD for longer is not an issue. It's actually an opportunity. Now, the problem is figuring out what is the ideal duration, which may not be 3 years. Maybe it's 1 year, but we need to work on that.
So, Hussam, let's shift over to you and ask you this question.
Can I have a quick question, please? Sorry,
Yes,
maybe I
please
missed
go
this.
ahead, Pati.
Yeah, Paolo, what was the median number of cycles of TTXD? Maybe I missed this during your presentation.
The median, I'm not sure actually.
But
Maybe I
the
don't know if
median duration was 20 months. So if you work backwards, it's given every 3 weeks. You can figure out the median number of cycles.
Yeah, something
So
like
the
30
median duration
something.
was 20 months.
Well,
so let
median
me
duration
ask.
of response might be different from median duration of treatment, but anyway, we'll find out later.
So let me ask Hussam this question because I've been dying to ask this question. We all know that these patients are doing so well with trastuzumab deruxtecan and pertuzumab, and I mean this is the first time we've managed to beat Cleopatra. But we also know that you cannot give TDXD forever in patients. It is associated with toxicity. I have a patient right now who is on TDXD I think this is her 67th cycle or something. And she still comes to see me every 3 weeks, begging me to stop the TDXD. But she started TDXD in her fourth line setting, so I'm not stopping her TDXD no matter what you tell me. But with a median duration of 20 months. And a part of these patients went on to have maintenance trastuzumab. Hussam, what are your thoughts about maintenance? Are there subgroups of patients that you may consider saying, okay, I'm going to be done at 20 and I'm going to go over to do maintenance therapy for these patients? Hussam? You're
I'll just
muted.
share
You're
something.
muted. You're
I
muted.
was muted. No, thank you, Shahina. I think the presentation and yourself answered the question a little bit. My feeling, the beginning of if you look at the trial DB09, the start of both trials, the responses were fantastic, both of them, and the overall response rate. But what I notice is that into the middle third seemed to be that's the biggest separation into the curves, which means what I'm worried about, if I switch back to a maintenance treatment that you could argue less effective than the TDXD, there's a possibility I lose the benefit that has been achieved early on. And to go for, I think your case having 60 something plus what we call cycle of TDXD this is the point, is that the patient's still here in fourth line and still alive. So my feeling about it is follow the toxicity profile, reduce the dose. Don't worry. I'm possibly, maybe Dr. Ahmed will agree with me here, that possibly I'm the easiest one to reduce the dose of toxicity is intolerable to the patient. So I don't have a problem from going one step down to two steps down. And then if the patient cannot tolerate it, is to switch into maintenance treatment, find something else. But we had a patient today, she's the first DB06, and I followed from one of my colleagues here, and into third year from ER positive. What I'm trying to say is that the price of the success, if the patient is doing reasonably well, continue. If having side effects, then reduce, and if not, switch to maintenance treatment. But as I said, and back in summary, the middle bit, after the third of that curve, they're close to each other, and then the separation happens more obvious, and the end is what matters.
So let me go back to Paulo. So what Hussam is basically saying is that if the patient's tolerating, I'll continue the TDXD plus pertuzumab. If there's toxicity, I'll switch to maintenance type therapy. But let me twist this around a little bit and say this patient has hormone receptor positive, HER2 positive breast cancer. A lot of disease. I mean, the viscera is completely studded with cancer. You start off with TDXD and pertuzumab. After 7 to 9 cycles, you image her. She's completely in CR. Are you going to switch over to a CDK4/6 inhibitor plus endocrine therapy? Or are you going to be like Hussam and say, look, there is no toxicity. Let her continue with TDXD.
See, Pablo very cleverly put the slides, the curves on, because you see at 6 months, the delta is about 6%. And then in 12 months, a little bit more to 13, and the separation went on and on to be 18 at 24 months. So that's what I mean.
We're talking about which trial now? Hussam, which trial are you talking about now?
This is the TDXDP. This is the
Okay. So I'm asking I know what you're saying, but I'm asking a totally different question here. Paulo, I'm going to go back to this slide that you presented on the hormone receptor positive and the hormone receptor negative. In DB09, you have now patina. I think the first question you need to answer is, do you think all patients with hormone receptor positive, HER2 positive disease, do you think they need CDK4/6 inhibitor in that first line setting? And if so, how many cycles are you going to give before you switch to maintenance, or are you just going to give TDXD plus P till toxicity? So you have three questions to answer.
No easy questions today, huh?
No easy questions.
Let me start to say that we have a couple of things that help here. First of all, where the metastases are, because I do think for patients that have visual metastases and brain metastases, these patients have an overall poor prognosis somehow. Like this trial is a box of patients with different types of disease. Patients that only have a couple of bone mets are different from patients with liver metastases and brain metastases. So if the patient had high-risk disease at baseline, such as liver mets, brain mets, visual mets, I do think that continuing TDXD pertuzumab for a longer time, it's ideal, and longer can be interpreted depending on the tolerability. Now, you have the extremes of the patient that tolerates amazingly. For that patient, I would continue even beyond 1 year, just because you want to maximize that first-line setting. and you want the patient to do well. But those are not too common. The average patient has some fatigue that worsens over time, some low-grade nausea, and those you can optimize them with those reductions. But at a certain point, I agree with you that you may want to switch to a CDK. The main reason is that because the data with Patina are very strong, and they're only in the first line. If in the second and beyond line CDKs, we have some data, but they're not great. So I do think if I can keep the patient for longer than 6 months, even with a complete response, if she's tolerating okay, I would do that. But then between 6 months and 1 year, I tend to think that if the patient doesn't have, very high risk features, switching to Patina is reasonable, with the idea of re-challenging with TDXT upon progression, which is something for which we don't have great data yet, but I think it's reasonable just because it's the best agent we have. But for patients that have very high risk disease at baseline, I would continue for longer than 1 year, just because you know that those patients have disease that is controlled because of treatment. But if you have a progression, that may be a bad situation.
So, Imad, I'm going to pick on you and ask you the question. Paolo's given a very diplomatic answer, and I love it. But let's take brain mets out of the equation and say this patient presented to you, no brain mets, was in visceral crisis because liver was fully studded and hormone receptor positive, HER2 positive. You give TDXD. 2 years down the line, patient is completely asymptomatic, no toxicity, and is in complete CR. Are you going to switch to CDK4/6 plus endocrine therapy, or are you going to continue TDXD plus pertuzumab? Imad, I can't
Yeah,
hear.
no.
Yeah. Okay.
If I have a drug which giving this fantastic response, patient with visceral crisis, and for 2 years the drug is beautifully effective, why I will switch? I don't guarantee any drug will give me the same efficacy, so I'll be reluctant to switch since she's 2 years on the medication. That means she's tolerating very well for 2 years. Drug giving an excellent response. I will continue same treatment.
Paolo, would you continue 2 years? I can make it 3 years as well if you want, but I'm just saying 2 years right now.
Now, once again, it really depends on tolerability, because if this patient is tolerating amazingly, not
Very
side
well.
effects, and
Very
I've seen patients like that, I tend to continue TDXT just
Okay.
because he's doing okay, it's not causing any trouble. It's probably better to preserve that even CDKs for later. But if instead it's the most common patient that there is some mild side effects, I would first dose reduced, and then at certain point switch. Now, is 2 years the right moment? It could be a moment, I think. And this is the biggest problem right now. We don't have a precise number. We oncologists, we love having algorithms. You give fixed
Exactly.
number of cycles and then you switch. In the first line, HER2 positive setting, we don't have this anymore. We have the art of oncology, and we need to figure out the best duration for each patient. For a patient that tolerates very well, I would continue TDXT. There is no reason to switch. But for a patient that is having chemo-related symptoms, I do think switching to a maintenance is reasonable, always remembering that palbociclib also has some side effects. We have to dose reduce, adjust, etc.
And I'm assuming you would add endocrine therapy for these patients
Always.
irrespective.
I think we saw so well, between Cleopatra, 18 months PFS, and here the control arm, 26. This shows how endocrine therapy can improve PFS. It's so relevant.
So, Dr. Basil, does the presence or absence of the PIK3CA mutation influence your decision about switching therapy at some time point?
It's a great question, but so if we are talking about, because in the Cleopatra maybe we didn't see that at the start of the publication, but with later us exploring PIK3CA and THP treatment, we know that it was underperforming. So that probably helps me to say which will be my standard of care anyhow, is to say TDXD is the right treatment for those patients, and it seems not even affecting it as expected. So probably it did able to antidote or counteract the issue about PIK3CA, which could be an issue with less powerful treatment like THP. So that's for sure. And people who are doubting or still believing they want to continue THP as their first line treatment, they better find PIK3CA status to do TDXD instead if they want to give still THP a chance. But otherwise, because I mean, you may still people, I'm not sure if this is a question you're going to come to, oligometastatic disease or some very low burden of disease. Should we give THP a try or not? I mean, my answer is no. But I mean, but in case this is where the issue is, and so I would definitely do TDXT in those cases.
So actually, my next question was on oligomet. So Paolo, I'm assuming that in the de novo group of patients, there were patients who had oligometastatic disease rather than having just full-blown visceral crisis or a lot of disease there. So say suppose you have, and I'm going to just give you a case over here. You have a 36-year-old lady. She's stage 4 de novo. She is, I'll keep it at hormone because hormone receptor negative is so easy. I'm going to keep it at hormone receptor positive. HER2 positive disease. She has one liver met that is biopsy proven to be metastatic disease. And you start off with TDXD plus P. She has a beautiful response after 6 cycles. We know that some of these patients can potentially be cured. How are we going to approach a patient like this?
So I think many questions here. The first question is, what about local regional techniques? Do they help, like thermal ablation, etc.? I will tell you, the Dana-Farber school is one that doesn't love local regional ablation techniques, which feels a bit bad to me because my father actually is an interventional radiologist, and I was born and raised thinking that we need to burn each and every lesion in the body. But in truth, for metastatic breast cancer, it's the drugs that cure the patients, not the burning. And so for these patients, I don't feel that doing something to the liver would make a huge difference. What makes a difference is if she has a beautiful response, which, as you're saying, she's having. So one good sign, having a beautiful response, she's very young. I do want to give more drug to this patient rather than less. This is not the 78-year-old lady which, I want to just palliate. There is a patient that potentially I can cure. And so I want to try to take her to complete response if I can, if she's tolerating, of course. And so these are patients for which, if I think of the switch to patina, I think of that pretty later on, not early on.
And what about surgery to the primary? She's stage 4 de novo.
I do usually keep a door open for that, just because it's very relevant, even psychologically for the patients. We know that HER2 positive disease sometimes can become a local regional issue if it progresses locally. So I think we don't have any good data telling us that this improves overall survival. Actually, we have the opposite data. But the main trial that looked at this, the ECOG-ACRIN, was mostly hormone receptor positive HER2 negative patients. So I think the question is open if removing the breast tumor is relevant. But for patients that have had a good response of disease, I do consider it after a while. Let's say after 6 months to 1 year at least, I think it can be considered if the surgical morbidity is not too relevant.
So and I have had patients like this on Cleopatra, 10 years down the line, they're completely cured. Like they still don't have any evidence of disease. And we did do surgery of their primary for a variety of reasons. So say suppose a patient has come on to DB09. Because it was so much simpler with Cleopatra, DB09 is not that simple. You give TDXD plus P, you give it, say, for a year, patient goes on to have surgery for the primary, no evidence of disease anywhere. Are you going to continue TDXD plus P post-operatively? It's a question that's repeatedly coming up and people keep asking me. So I said, I'm going to ask Paolo tonight.
So I do feel removing the breast here doesn't play a role. I feel if you remove it or not,
No.
meaning
Patient had breast
duration.
conserving surgery, not removing the breast. She had breast conserving surgery
Sorry, removing
and
the breast tumor.
radiation. Yeah.
Removing the breast tumor, meaning
Okay.
if I'm thinking of a duration, let's say I'm thinking in my mind that this patient needs more, I will give more irrespective of if I see tumor or not. Now, of course, if I see a brilliant response, I'm kind of inclined to think maybe now I can maintain. But once again, this is a young patient. You want to try to have your best shot at curing her. So I think if she's tolerating very well, if she's not having much nausea, much fatigue, continuing beyond 1 year, totally reasonable. If she's struggling with side effects, that's different, and it's a discussion. I think can be an open discussion with the patient. Some patients will just tell you, please, doctor, decide. What would you do to your sister, whatever. But some patients instead love the idea that they can decide. They can decide how aggressive to be with themselves. And some patients will say, if this allows me to have the longest PFS in the first line, the highest complete response rate, etc., I want to continue. And that patient should be allowed to continue. Some other patients will say instead, I don't care. I have this mild nausea, I don't want it. Let's try to change to something different. So I think for the first time we have options, which makes our job so much harder. But overall, the simple thing, exactly. But the simple thing that you don't see disease in the body, I don't think it's enough to stop.
Okay. So Sonia, what are your thoughts about using DB09 first line in those patients with hormone receptor negative, HER2 positive breast cancer? Do you use it for everyone, or are you picking and selecting your patients?
Yeah, very good question, Shahina. I will be choosing the patients, honestly, depend on the age, performance stages, if they have brain mets active, non-active, and specifically if they have, like we have some patients, they have lung pneumonitis, fibrosis initially before to present to us, some cardiomyopathy, and they will choose my patients. I mean, the idea of DB09 is really brilliant. I just started one patient, being honestly, on DB09. Although she is like 70 years, but she's in a very good performance stages, inflammatory bilateral breast cancer with nodal disease, very good tolerability and excellent response to start with. And she has metastasis also to the bones, but she's in no comorbidities elsewhere and no history of lung fibrosis. So these are the patients for whom I will be mainly going for DB09. Now, if the patient has active brain metastasis, so this is the patients I will discuss in MDT also, whether I will go for like radiation therapy, stereotactic brain radiation therapy. Will I use pertuterace taxane to have faster response, or we go to DB09? Although the TDXD is the best for brain metastasis, but I will still discuss these patients in my MDT meeting.
Okay. I have to say that when I have patients with brain mets and I use TDXD, I wait to see if the TDXD is working before I go and do anything to the brain. But I'd like to ask Paolo this question. We've seen some very conflicting data recently. There was a nice paper in JAMA from Memorial that actually suggested that you have to have a long gap from TDXD before you do anything to the brain. Otherwise, you would increase the risk of radionecrosis of these lesions. Yet we have another group that's recently published saying there's no difference. You can use TDXD concurrently, maybe not concurrently, but close up with radiation therapy. What is the practice at Dana-Farber?
Yeah, that's an important question because there's been discordance in the data, as you mentioned. The one from MSK basically had a lot of resonance because it was published in a good journal on JAMA Oncology. But overall, it was kind of a small cohort and mixed. Patients receive either TDXD or TDM1, other ADCs. And so we tend to believe it, but realize that it's like not the perfect answer. At the same time, also the other cohorts, there is an Italian real-world study which found no difference in radiation necrosis. Overall, we tend to be cautious, and cautious means trying to have a gap between the last TXD and radiation. That gap needs to be at least a couple of weeks, ideally 3 weeks. It depends on how aggressive the disease is. But I think, if we can stop for 3 weeks, give radiation, and then restart 1 week later, you just basically open the window between 2 cycles by 4 weeks instead of 3, which is not a major issue, but at least you try to be safe, not to have the patient have the drug in her body while she's getting radiation. Is this needed? I don't know, but it's better to be safe in this case. So at least 2 to 3 weeks window before radiation.
Absolutely. And like I said, I mean, from my limited experience, I know you have a lot more experience using TDXD. I like to wait to see TDXD work because 9 times out of 10 it works very well that you wouldn't need to have radiation therapy. And then the radiation oncologist gets upset that they, took them out of a job. Basil, you have your hand up. You have a
That
question?
is correct. I'm waiting for the beautiful discussion to end, but my questions is about what we expect that we are going to be using soon, HER2 DX or circulating DNAs. We know that's coming, to the practice, and the question is, should we or should we not be using HER2 DX, for example, to decide about in the context of selection for patients who have, again, metastatic disease or low burden of disease, and they have good, factors like the HER2-DX score, to decide about first-line therapy. Is that going to be a possibility of treatment selection in the future? And same goes when we talk about in the, let's say, maintenance part and the circulating DNA. Could that be another factor to choose when to switch to maintenance part or not?
So if I'm
I
going
mean,
to allow
open for discussion. I mean, it's not
Absolutely. I'm going to let
quite a
Paolo answer that, but before he answers that, just to give you my 2 cents of what I think about ctDNA in breast cancer, I think we're not there yet. I think there's a lot of data in triple negative, HER2 positive, as well as hormone receptor positive. I think it works really crappily in hormone receptor positive. I think we need a lot more work over there. I mean, I always quote the Monarch E trial where only 70 patients had ctDNA positive, and the rest that had like 10 lymph nodes that were positive didn't have any ctDNA that was positive in that study. So again, grain of salt. And HER2 positive, I think also there's a lot more work. I think where it's really going to work maybe is in the triple negative, but I leave Paolo to answer that question for you.
Now, I think it's an important topic to discuss because we need biomarkers. When you have different treatment options that you can choose from, that's where biomarkers become very important. Now, as you mentioned, I don't think we are yet there. So ctDNA, we expect most of these patients to clear ctDNA just because HER2 positive disease is so sensitive to treatment. And clearing ctDNA alone, I think, is not a justification to de-escalate, to stop the TDXT, to move to maintenance. Now, another question instead that we're looking at, there's a colleague of mine here at Dana-Farber called Stefania Morganti, is looking at exceptional responders to think, can you stop treatment after 5 years if the patient is ctDNA negative? And at that point, it's different because that's a long time after having stopped cytotoxic treatment, and there is some promising data there suggesting if you use a ultra-sensitive assay and there is no ultra-sensitive ctDNA, maybe you can safely stop. But we're still in early days there. What about HER2-DX? So HER2-DX, I think there's very, very promising data for early stage HER2-positive breast cancer. And actually, if I had it available, I would use it every day for early stage HER2-positive, just because it does add important prognostic information. For metastatic breast cancer, instead, early days. So they showed some data with HER2-DX in Cleopatra, actually from the samples of the trial. And they showed that the main thing it did is dissecting a small population of patients that have lower ERBB2 expression and worse outcomes. And so, in truth, that doesn't really guide your options, because for those patients, you would use TDXD pertuzumab, but also for the other patients, you would. So I think early days, we just published last week, I think, a paper looking at HER2-DX, if it predicts the activity of TDXD, and it kind of does, but in a cohort of 51 patients. So acknowledge our cohort was small. So I think, do we need to keep looking? Yes, we need a good biomarker that tells us these patients need TDXDP, these other patients can do well with Cleopatra patina, or even just endocrine therapy. But I think it's going to take still some time, some efforts. And for now, I would not use these biomarkers for selecting treatment. But if they are available, it can be still interesting, for instance, at certain point to look at ctDNA just to understand if to continue HER2 treatment forever, or if at certain point, after many years, you can stop. And this year, by the end of the year, we hope to present the data from Stop HER2, the first prospective trial to look at stopping trastuzumab. So for that population, exceptional responders, hopefully biomarkers will help.
So
I
Paulo, you
agree with
mentioned
I agree with everything said. I think we're not there yet. We could be using it as a tool to decide about maybe therapies in the future, but that's the idea of all those excellent, innovative factors is that maybe this will help us after all dissect and decide about what is induction, what is maintenance, who to stop. I think those are very three important milestones in the HER2 therapy treatments. I do agree at 2026 where we at is induction. I think is clear now. TDXD I think is really going to be an important induction part. I think the time for maintenance seems is based on tolerability more than anything else, and when to stop is I think will come soon. I don't think we are like with my friend Sonia here. I don't think we have a Sonia trial style in the HER2 therapy where we are going to decide, shall we keep TDXD for second line? I think this battle I think has already been lost because 1/3 of patients not continuing second line therapy is a big deal, is a big number, and I think we need to save those people by giving them the most powerful drug in the beginning. And so, unless we have a very good biomarker like HER2-DX or say maybe something else will come in the next 10 years, I think we should go with the TDXT.
I think Basil's standpoint on DB09 is quite clear. I perhaps disagree slightly. I don't think everybody needs DB09 up front. I think 99% of patients need DB09 up front. I still think you have a small cohort of patients where you could potentially get away by not giving such toxic treatment. And the patient that I can think of at the top of my head is that elderly patient, that patient with one bone met, that patient with hormone receptor positive disease, where perhaps patina might be the better option for that particular patient. So I think every patient, and that's the art of individualizing therapy. I think every patient needs to be discussed in the MDT to individualize therapy. Before we
That
go
comes
into
what
the
tolerability
discussion,
is, Shahina,
yes,
right? That's
100%. We're
tolerability.
coming to that. Basil, we're coming to the
Yeah.
No, I mean,
tolerability.
when you
Give me a
mention a
chance.
frail patient,
Give
that's what
me
I
a
meant by
chance.
tolerability,
Yes,
Shahina. Someone, if it's
absolutely.
not
Give me
tolerable,
a
you
chance.
switch.
Give me a chance. So, before we go into the tolerability, because we only have 8 minutes, and I know Paolo has a clinic to go to, with hundreds of patients standing outside wondering what the hell I'm doing with him in a closed room. For before we go into that, you brought up something very interesting, and that is HER2-DX. And I've always wondered, and I know I've seen the small cohort of patients that you've published. Um, I've always wondered, could this be a potential platform that could distinguish between using trastuzumab pertuzumab versus using TDXD in that limited burden of disease patient with metastatic breast cancer? So you're really looking at those patients that are highly, highly responsive because HER2DX can actually identify that, where you potentially don't need TDXD plus P. Do you think that could be something we look at in the future? Not tested yet, but something to think about.
It's a great point. Now, there is an issue there because, the patients that have the highest HER2 expression are the ones that are most likely to do well with both regimens, with,
Exactly.
Cleopatra or TDSC. But at the same time, these patients that tend to have a better prognosis are also the ones that are most likely to be cured. And you may want to use in these patients the best shot to cure you have. For instance, we have a trial, kind of a crazy trial, but I love it. It's called Sappho. I don't know if you're aware of it, but it's
No.
like this
Yeah,
78 patient phase 2 trial where we try to cure metastatic HER2 positive breast cancer with basically adjuvant-like treatment, meaning 3 months of THP, 3 months of TDXD, and then you complete
Oh, I've
1
seen
year
that.
with
I've seen the
TDM1
trial
Yeah,
schema.
cut
Yes,
it,
that's right.
TDM1
and then you
Yes,
continue
yes.
with HP to cancer. So it's like a little crazy, but in truth, that's something you may want to try for a patient you think you can cure. And this is only for de novo patients. You don't want the patient that had recurrence because you know that that tumor is trastuzumab resistant. It's maybe too hard to cure. But a patient with good prognostic features, maybe you can cure it. And this is why I struggle to think of a prognostic biomarker to decide what to use in first line, because better prognosis means, okay, maybe they do fine with Cleopatra, but they could do even finer, even better with TDXD pertuzumab. So definitely to study, but it's not going to be easy.
It's not going to be easy. So in the last couple of minutes, I want to talk about the safety and tolerability of TDXD. Fatih, what are your biggest concerns using TDXD plus P in the first line setting in these patients with metastatic breast cancer or HER2 positive?
Yeah, I mean, I think we've been using Cleopatra now for more than a decade, and it's honestly speaking, it's very good tolerated,
Really?
especially with the
You've been using
uh,
it for more than a decade? Has it been approved for
yeah.
that long?
No. I said
I'm
Cleopatra.
joking.
I'm just telling you now where we come from to and
Yes.
where we're heading to.
Yeah.
So we came from Cleopatra, which is really very good tolerated regimen, and all of us have many patients with for many years. But TDXD is a bit more challenging, especially I think in our region and especially with my patients. I think fatigue is probably one of the issues. Nausea and vomiting, since we learned to be more proactive and use the three antiemetic regimen, it doesn't really it's not really a big issue. We can handle it. We have I agree with Dr. Hussam in the beginning. We have kind of a low threshold to reduce the dose. So we try to maintain that as long as possible. But I think the elephant in the room that it's a drug might be difficult to continue for years, as we did with HB. And actually, I looked while you are talking about the median cycles on DB09 was 13 cycles. So
20 months,
yes,
isn't it? Okay. All right.
DB09 was 13 cycle, yes. So basically, we are all for it. The data is very impressive. The BFS is unprecedented, but we need to keep monitoring our patients, and especially with the emerging data, patina is also as impressive. And I think for the hormone receptor positive, there's also a good idea to switch whenever you feel your patient is struggling, either tolerability or even we shouldn't forget the cost as well. Maybe we are lucky. We are in a place where we can afford these expensive drugs, but there are some places where alternatives might be a good idea, especially with the kind of a cheaper versions of with the biosimilars and the generics of palbociclib and all of that. So I think, yeah, we will all go for it. We will give the best shot to our patients, but we need to keep monitoring them and keep the quality of life as important as the length of life as well.
No, 100%. In fact, a lot of my patients fear the long-term alopecia that's associated with TDXD. But what I've noticed, and again, my limited experience, Paulo, you have a lot more experience in TDXD than I do. I've actually seen patients lose their hair and then it grows right back when they stay on TDXD for a long period of time. And I tell them, look, your hair is going to grow back. So before we end, I have 2 minutes. Paulo, I need you to please explain to me why HER2 climb, although a positive trial, those numbers are just not impressing me. They are worse than what we saw with DB09, patina, and perhaps even a little bit about, I expected a lot more. What are your thoughts here? Why did HER2 climb disappoint? I think it disappointed me.
Yeah, I think we have a good answer for the ER positive patients because only a fraction of those receive endocrine therapy. So you
Okay.
would expect worse outcomes. What
Yes.
about ER negative? I wish I had a brilliant answer. I've been asking this question to the most brilliant people I know and I meet, and I was not able to find a good answer. So sometimes you need something like this to remember. Careful with cross-trial comparison. I wouldn't just look at the medians and say tucatinib doesn't work. I would say in this trial, in this experiment, this is how it went. Do we have a brilliant answer to understand why? We don't. We only do for ER positive. For ER negative, we just accept that it reduces the risk of progression. But I agree with you, it's such an enigma.
Okay, last question, Paolo, and I have to put you on the spot for this. Patient has limited burden of disease, very, very limited burden of disease, but has brain mets. You going to use tucatinib-based protocol or TDXD-based protocol?
I think, DB12 made us all switch mind, like TDXD that
Okay.
has higher response rate, higher PFS, higher everything than tucatinib. I would just do tucatinib pertuzumab for the longest possible time. Tucatinib, just if the patient really cannot tolerate TDXD anymore, but brain mets to me equals TDXD as
TDXD.
much as possible.
Okay. Marishi, you've got the last word here. Do you agree with Paolo? I think he should say TDXD plus P, but he only said TDXD. What do you say, Sam?
No, TDXD plus B for sure. I think this is a game winner if you have any concern about disease progression within the brain, no doubt about it. I'm just going to mention last point, just to say people tolerate a TDXD different places in different area of the world. When in practice in the UK, you have the average number as reported per trial. And I always heard about the Asian Japanese, they have a higher chance of pneumonitis. And I come to the UAE, it's not just what being published. I know it's a small case cohort, but 100 cases or something, but less pneumonitis.
All right. So thank you very much. You've all been great sports. I think we've had a brilliant discussion. Thank you, Paulo. I know you need to run to your patient. I wish you all a pleasant evening. Those of you who are in my part of the world, I hope you have a pleasant day, Paulo, and you don't get run down by too many patients and too much administrative work as we all have. And I hope to all see you in the future in better times. So thank you very much.
Thank you for the amazing moderation.
Thank
Good night.
you.
Yeah.
Bye.
Good
Good
night.
night.
And
Bye.
Paulo referred to IR. Yep.
Good night.
Thank you.
you.